Radiology in the core of diagnosis. Professor Rania.
Thank you all for your presence. Thank you, Walid, for this amazing presentation. And now I will be talking on the symptomatic young adult hip from the radiology point of view. And we always encourage this kind of communication between us, the radiologist and clinician. We need to consult each other. We need to communicate with each other to select which imaging modality is appropriate for the patient, which imaging finding is of relevance and significance to be documented in our reports, and to reach a proper diagnosis. So most of the young adult hip pain is caused by impingement or instability, and both of them are clinical diagnosis or clinical description. What really matters to us as radiologists is to understand what is lying beneath, what is the reason of the pain. So in order to simplify things, I like to classify the reasons of the young adult hip pain into either an extra bone, the presence of an extra bones, a deformed bone contour, abnormality of the acetabular coverage, whether it is an over or under coverage, or an abnormal rotation axis of the lower limb. And this is the first example, plain X-ray of the hip, AP standing view, and I'm sure that everyone here in this room can appreciate the huge cam. MRI, high resolution coronal images, beautifully showing the, okay, so there is, I'm happy that the arrow is showing the labrum tear. It is clearly showing it. There is, this is a high-grade labrum tear. There is complete detachment of the labrum from the osteolabral junction. And I think you can also appreciate the presence of the low signal line, which represent a detached, torn cartilage flap. Sagittal images of the same patient confirming the labrum tear. And this is a collection of images of the patient with the cam, labrum tear, and chondral delamination flap. So this is one of the classic cases. Another example, plain X-ray of the pelvis and both hips, AP standing. And yes, there is a cam, but there is also an impression of some sort of dysplasia. So when we measure the lateral central edge angle, it is reduced down to 18 degrees, whereas the normal range should be between 25 to 40 degrees. MRI of the same patient, high signal within the labrum, disrupting the contralabral junction, and few cyst-like changes at the osteolabral junction. معلش ممكن البوينتر في بوينتر عندي هنا في Okay, so to again summary of images of the patient who had adult hip dysplasia with ممكن بس تشغلي البوينتر أو هنا أي حاجة. Thank you. Okay, so this to make things easy, we have adult hip dysplasia, we have labrum tear, and some sort of chondropathy. Third example or third patient, plain X-ray of both hips, AP standing. And we can see that there is an overhanging of the anterior acetabulum wall, the figure of 8 or the crossover spine, and this is characteristic of acetabular retroversion. But many times this is false positive in X-ray, so we need always to do a CT. And in the CT, we look at the 3D reconstruction images, and yes, they confirm the abnormality. Also the axial images. And when we look at the axial CT, it is very important to scroll down through the apical, down to the central sections where you can see the full circumference of the femur head and the fovea capitis. There is enlargement and overprominence of the anterior acetabulum wall, which is usually should be smaller than the posterior, but in this patient it is larger. And the acetabular opening is directed posteriorly rather than anterior. Another example of acetabular retroversion, but this patient had advanced stages, advanced changes probably he presented later in his life. You can see definitely the labrum is torn, it is actually missing, and there is advanced chondropathy, there is a detached osteochondral fragment from the femur head, extensive subchondral bone cysts and edema on the acetabular side, so this patient unfortunately reached the stage of osteoarthritis. And now the rotation abnormalities. So normally the femur neck should be in a state of an external rotation compared to the distal femoral transcondylar axis, and the angle in between should be in the range of 20 to 25 degrees. So an excess anteversion or an increase of this angle or a reduction of the angle, both are abnormal and both result in pathological pain. We have an example of a patient who had a reduction of the femur neck anteversion. Actually, it was reversed, so it was in a retroversion. And this is the arthrography of the same patient. You can see the labrum markedly thinned, irregular, diminutive. So this is a chronic labrum tear. There is extensive denudation and fissuring of the cartilage lining. So femur neck retroversion, labrum tear, and chondropathy. So to summarize, young adult hip might suffer from pain because of extra bone or deformed bone contours like the common cam and pincer. We also appreciate the presence of an extra bone or a hypertrophic bone at the level of the anterior inferior iliac spine, which represent old rectus femoris avulsion injury. And this is what we describe as subspinous impingement. Another possibility is abnormal acetabular coverage. It could be an overcoverage like in cases of coxa profunda and retroversion, or an undercoverage like in dysplasia. And the third and last possibility could be abnormality of the femur neck rotation or version, whether an excessive or reduced anteversion. And now we will shift to another category of lesions like the synovial-based ones. So MRI of a female patient, she had a labrum tear and she had extensive subchondral bone cysts and erosion-like lesions all through the acetabulum. So first impression was query degeneration, query early osteoarthritis. But whatever is happening here on the acetabulum side is disproportionate from what is going on at the femur side. And it is also disproportionate to the amount of joint space reduction and loss. So we had to shift our thinking to another possibility. And we can see the capsular distension with synovial effusion and synovitis. So whenever we suspect inflammatory arthritis, we need to check the other joints, and here is the wider field of view where we can see bilateral sacroiliac joints, fatty metaplasias, and chronic erosions. So we directed this patient to rheumatology for further workup as a seronegative arthritis. And this is the opposite scenario where the patient was already under the care of a rheumatologist for many months, and then he was not satisfied, and he realized that the patient is not responding well to his management, to his medications. So MRI, and he referred her to the orthopedics. High-resolution MRI shows synovial proliferation, and this is much more than just synovial thickening. It is mass-like changes, and we added gradient echo images, which beautifully showed the blooming artifact and signal drop from the hemosiderin, which is characteristic for cases of PVNS, or the new pathological term, which is tenosynovial giant cell tumor. It is a monoarticular disease, and it is more common in the knee than the hip. However, MRI is very helpful, especially adding the gradient images. Sometimes the pathology is bone-based, like this young chap who had extensive bone marrow edema of the femur head and the neck. And a zoomed image or a zoom in, you can appreciate and recognize the low signal subchondral fracture line, which is parallel to the femur head circumference. So this is a classic acute subchondral insufficiency fracture. It is more common in males, 3-to-1 ratio. When it comes in females, it has a classic picture in pregnant females and postpartum females. For these patients, we always offer a follow-up MRI in 4 weeks interval to make sure that the edema is resolving, that there is nothing underlying the bone marrow edema, and also to make sure that the head circumference is maintained. There is no any signs of collapse or structural collapse or flattened surface. The differential diagnosis is also the avascular necrosis. There is usually underlying risk factors. The most common is steroid intakes, and the difference is usually in the double-line serpiginous sign, which is the necrotic margin, like any infarct happening anywhere in our bones. And this is my final example. greater trochanteric pain syndrome in a patient who had gluteal tendinopathy. The tendon thickened, high signal, and there is this low signal focus, which is calcification, calcific tendinitis, beautifully also shown on the ultrasound. And the reason we did an ultrasound for this patient that we offered him an injection, and you can see here the bursal distension by a solution of corticosteroid and local anesthesia. So to conclude, we can appreciate or can categorize the different reasons of pain of the young adult hip into impingement or instability cases, synovitis, PVNS, acute subchondral fractures and avascular necrosis, and different pathologies and tendinopathies. We always start with an X-ray. X-ray is the starting imaging modality for these patients. It should be done in AP standing view. We look for the bone contour and the coverage, but it's very important to assess the joint space and to compare both sides, because this is important in decision making. When we do the MRI, we always do it at a 1.5 or a 3 Tesla MRI. We use a surface coil and we apply the high resolution protocol, and I will come to this in my next slide. CT is recommended for some, but not for all the patients. The 3D images are very helpful to assess the bone volume, the bone contour, and also measurement of the angles in a rotation profile protocol. Ultrasound is helpful to assess the tendons. Dynamic ultrasound is used in the snapping hip syndromes, and it also helps in guided injections. So this is my screen setup for each patient having a hip pain. I always look at the X-ray. I always start with an X-ray and AP standing position and at least one view. And then I look at the MRI. And when I do the MRI, I obtain two large field of view sequences. I do it in a coronal T1 and axial stare. In coronal T1 is very helpful to look at the bone marrow, any bone marrow edema, pathology, infiltrates, and so. I also have a look at the sacroiliac joints and symphysis pubes. Axial stare is very helpful to detect any signal changes in the muscles and tendons. And then the high resolution images, we obtain three sequences, an axial, oblique, coronal, and sagittal. And these three images are obtained in the PD FATSAT. They are very helpful to comment or to assess the labrum, the cartilage, and the subchondral bone. And final slide, CT rotation profile. What is the CT rotational profile? We acquire 3 axial sections at the level of the hip, knee, ankle, and then we ask the operator to measure 3 angles. First angle is the acetabular version angle, which is the angle between 2 lines or 2 axes, one of them connecting the anterior and posterior acetabulum wall, and the other one perpendicular to the horizontal axis. The femur neck version angle is the angle between 2 lines, one of them connecting the mid points of femur neck and the femur head, and the other one parallel or tangential to the distal transfemoral condyles. And the third angle is the tibial torsion between 2 lines, one of them tangential to the posterior tibial plateau, and the other one is transmalleolar, connecting the midpoints of the medial and lateral malleoli. So the acetabular version angles give us an impression about the under and over coverage, and it should be in the range of 15 to 20. Femur neck version give us an impression about the femoral neck rotation abnormalities, anteversion, retroversion, and it is expected to be in the range of 20 to 25. And finally, the tibial torsion to have an idea or an impression whether any superior axis abnormality has been corrected inferiorly or not. And thank you all for your attendance and for your attention.